All right, welcome back everyone. So this is section 2, uppers and downers. So in this section, we're going to actually cover 3 chapters, chapter 6, chapter 7, and chapter 8. And like I did before, I'm going to go through, I'll have timestamps in the video for each of the chapters. So don't feel like you have to sit and listen to each one all at once. You can break it up and listen to one at a time. All right, so let's start off with chapter 6 here. Chapter 6 is going to cover stimulants. So for stimulants here, we're really looking at, drugs that are going to increase a person's awareness, general physicality, mental alertness, things like that. And there are some stimulants that are both restricted, so think of things like cocaine or amphetamine, as well as some readily available stimulants as well, like caffeine or even nicotine here. So as we go through this chapter, we're going to cover a few different things. We're going to start off and talk about cocaine first and go through some of the components of that, specifically its history, different forms, pharmacology, and then positive and negative aspects to this drug. And then we're going to talk about amphetamines here, so the history, pharmacology, and then some benefits as well. Some of the other more readily available stimulants like caffeine and nicotine, we're going to save actually for later chapters where we talk about more familiar drugs to us. So this chapter on stimulants is focusing primarily on these two. All right, well, let's go ahead and get into it. And let's start off by looking at the history of cocaine. So cocaine actually first started off being used in the Andes, and it was produced through what's known as the plant coca. So the coca plant or the coca leaves were actually where this first was used. And it was actively cultivated for over 800 years actually, and actually ended up becoming an important part of the Inca culture. It was used in religious ceremonies and also as a form of currency, which is pretty interesting to me. So some people in the Andes still actually chew these leaves to give small amounts of coca, and it can help reduce fatigue and increase alertness and things like that. So cocaine wasn't actually used in Europe until really the last half of the 19th century. So it wasn't quite as early on and developed in that area. And so it was actually originally used as a form of coca wine. And the leaves were extracted and again also became used for things like lozenges and tea and things like that. It did also have some medical use as well. So a lot of the medical use of cocaine was derived and used sort of for this anesthesia, effect of the drug. It was used in local anesthesia for certain areas and was developed by Dr. W.S. Halsted, who was referred to as the father of modern surgery here. So again, it is actually still used even today for some small specific local forms of anesthesia. It also had some psychiatric uses as well. So famously, Sigmund Freud actually studied and recommended the use of cocaine as a treatment for depression. So we know now maybe that's not the best approach, but he was one of the proponents of using it for that medical purpose. We've obviously developed better practices now, and do not rely quite on cocaine as much, or really at all that we used to. It's also been used in medicines and elixirs. So you can see sort of the image here on the right. They used to use it in different types of medical drops and things like that. So toothache drops that actually contain small amounts of cocaine to help alleviate some of the pain associated with those small specific areas. And again, that's where we see really the most beneficial effects here coming from that acute pain relief in specific areas here. All right, let's talk about some different forms of cocaine. So one of the early forms of cocaine was actually coca paste. So this is basically like a crude extract that comes from that plant. And it's the extract of the coca specifically in a form of paste. And oftentimes this was mixed with things like tobacco and it was, smoked in that way. We also have cocaine hydrochloride. So this is basically a water-soluble solution It's a form of salt, and this can be snorted or even injected intravenously. Then we have the freebase form of cocaine. So this is basically the extraction of cocaine into a volatile solvent, so like an ether or something like that, a vapor. And this basically results in this freed cocaine base that can be heated, and the vapors can then be inhaled. And then finally, of course, we have crack cocaine, probably one of the more common or known forms of cocaine. And this tends to be either, in both a powder or a rock-like substance. Both are actually the same substance, but just in different forms. And oftentimes this is what is smoked or baked into different things like that. Let's talk about the pharmacology now of cocaine. So the pharmacology of cocaine is kind of complex. It works in some different ways. But as you can see on the image here, when we talk about the mechanism of action, this kind of is referring back to some of the previous chapters of the first section here. But we're thinking about how different drugs are acting on this synapse or this mechanism of different medications here in this case. So what we have here is we have cocaine, you can see, actually acting in this synapse and acting on these neurotransmitters, in this case of dopamine. So cocaine actually acts to block the reuptake of both dopamine, serotonin, and norepinephrine. Remember, we talked about those in the last section. And what you can see here happening in this image is the cocaine is actually going and blocking those reuptake receptors. So what you have happen ultimately is that the dopamine in this case can't be absorbed back up into that axon terminal, and instead remains in the synapse and binds over and over and over again, like there was an excess amount of dopamine. So what I actually want to do here is I'm going to switch over, and this is a really cool website. It's called Mouse Party, and what this has here actually is it's a pretty cool demonstration of different medicine or different drugs basically that people have used, and you can see each of these mice is affected by a different drug. And so what we're going to do here is we're going to grab actually the one that is under the influence of cocaine, and if I click him and drag him into the chair, what's going to happen is we're going to analyze this process and see what's really going on down at this neural level. And so if we kind of zoom in here, what we end up seeing is, like we saw in that picture, we see the yellow little dots there are the dopamine receptor or dopamine neurotransmitter. And we can see what's going on here with these little purple transporters. Those are what pull the dopamine from the synapse back into that axon terminal. And then we can see on the dendrite down on the bottom, those dopamine receptors that are actually what receive the dopamine neurotransmitter to then pass on that signal. And so this is a normal functioning process that we've seen so far. But next, if we add in the factor of cocaine, right? So what cocaine does is it goes in and it actually blocks those transporters so they can't reabsorb the dopamine in this case. And so because that dopamine doesn't get reabsorbed, it stays in that synapse and continues to bind over and over and over again with those receptor sites. And so we get this effect of increased dopamine, factors, or it appears as if there's more dopamine simply because it's not being taken away and it remains there, able to be used. And what we see with cocaine specifically is we see this acts oftentimes in the areas of the brain related to the reward pathways and things like that, and oftentimes as well it factors into some of the parts of the brain that control voluntary movement. And so that's why we get a lot of people that sort of fidget or move a lot when they're under the influence of this medication. All right, so let's eject this mouse. We'll come back to this for another one during this section, and we'll save some of these other ones for some other demonstrations here as well. All right, so let's switch back over to our section here. So let's talk. We now know kind of about what happens specifically at that neural level, but how does the actual absorption of this drug happen? So oftentimes people tend to, when we're talking about coca leaves in that base form, we see people chewing on them or things like that, and that tends to have a pretty slow absorption and onset of the effects. So we don't see that quick, rapid, effect of this. It's slower. It takes time to kind of get through more of the digestive system and into the bloodstream. When we look at things like snorting cocaine, which might be more commonly associated with the intake of this drug, we see that absorbed through the nasal passage, right? And this often has a pretty rapid onset of those effects. So this is a much quicker way of getting this drug into your bloodstream. And then, of course, we also could, administer this through things like intravenous injection, right? So delivering a high concentration either into, the vein specifically, or into other specific areas of the body. And this also delivers not only a quick response, but a pretty high concentration response here as well. And so we get pretty rapid, but and oftentimes more brief effects the faster this is introduced into the body. We also have to talk about how it's eliminated from the body as well. So it not only takes time to get into the body, but how quick it's removed from the body can show an effect on how much we see this activated as well. So cocaine tends to be metabolized by different enzymes in the blood and the liver. And it has a half-life of about 1 hour. So half-life basically means how long it takes for 50% of the medication to be eliminated or to still remain. So half of the medication is gone at that point. And so it has about 1 hour. Now, it's not saying that 2 hours later it's all gone. It's really saying that if after another hour, half of what's left is gone. So it has this diminishing effect, but it does still take time to get that out of the body. But we use this half-life measurement for a lot of different areas of understanding how long things remain in our body. So it takes time for it to get out, and it takes time to remove it. Typically, these major metabolites have a longer half-life, normally about 8 hours are more common things that we tend to see. So cocaine is a pretty quick drug to be eliminated from the body. All right, let's talk about some beneficial uses as well as some causes for concern when it comes to cocaine use. So some benefits, we've talked about these a little bit already, but the idea of local anesthesia, right? So the idea of numbing or reducing the sensation of very small, minute areas of the body. And this was used very commonly in early surgery, as well as dentistry. This was pretty common with that as well. And it's been used medically since about 1884, so for a little while, but obviously it's been replaced by some modern things more recently. We also have some benefits in regard to different surgery. It does remain in some common surgeries, specifically for like the area of the nasal passage, or even sometimes the larynx or the esophagus. So it does still have some current uses, but it is much less common than it used to be. Let's talk about some concerns, or some concerns, cause for concern here with this drug as well. So of course we have different types of toxicity. So we have acute toxicity, which basically means what are the risks short term using this drug, in a short time period. What do we have to worry about in terms of that? And so generally speaking, there's very little evidence that suggests that acute toxicity or in small amounts has a detrimental effect on health. So in that regard, there's not a lot of evidence to show that it's, has a lot of concern in that area. But with larger doses, it does have issues, especially on the central nervous system specifically, and can also lead to issues with respiratory or even cardiac arrest. So it does have some cause for concern here, even on the short-term time spectrum as well. Then, of course, we have chronic toxicity. So this is the idea of repeated use over longer periods of time, and oftentimes taken at increased doses over time to get that same level of effect. Oftentimes, this leads to states of increased irritability, restlessness, and even paranoia as well. And it can ultimately result in a form of paranoid psychosis, which is a much more heightened state of paranoia and psychological disturbance. Now, most people do seem to recover once they remove the drug and it removes from their system. But of course, this is still something that is a pretty big cause for concern when talking about this here. In terms of addictive potential, so it does have addictive properties in some users. Specifically, animal and human studies have shown that cocaine tends to be a pretty reinforcing drug, right? So it has a pretty quick response, and you get that benefit really fast, and it draws people and animals to want to repeatedly use it over and over again. Also because the effects tend to go away pretty quick as well. So you have that repeated desire to use it over and over again. Now, what's interesting too about cocaine is there are some reproductive effects that have been studied here as well. The idea of sort of the crack baby phenomenon. And so oftentimes the media reports have really overstated the expected long-term effects of cocaine exposure on some of these developing fetuses. So more recent studies tend to indicate that there's really no consistent negative association between parental cocaine exposure and several developmental measures. Now, that is to say, that obviously, we shouldn't be reinforcing this or saying that this is okay to do, but that more recent studies have shown a weaker link than we originally thought. And then, of course, but cocaine use still during pregnancy has been shown to increase risks for things like miscarriage and things like that. So there are definitely some reproductive negative side effects here when talking about cocaine. All right, let's now switch over to amphetamines, which is a different form of stimulant. But we're going to go through these a little bit, talk about the history, and kind of go from there. So amphetamines originally are from the general area of ephedra, which is the general name, and was often made through a Chinese medical tea called muhang, which is again a form of medical tea in this case. And it was used to treat things like asthma, and it stimulates those branches of the autonomic nervous system that increase that alertness and that awareness. So it's known as a can't speak. It's known as a sympathomimetic drug. Trying to read that word here. Oh, and we don't have it showing up here. So again, when we're looking at this, there are different forms of amphetamine here as well. So let's talk about some of them. So we have things like some treatments that it's been used for are things like asthma, narcolepsy, also hyperactivity in children. It's used as a form of ADHD treatment, as well as different appetite suppressant medications here as well. General use of stimulating sort of those parts of the nervous system. There is some interesting use of amphetamines during wartime procedures. So they've been given to soldiers at different points to increase their efficacy during battle or during their general performance, because it makes them more alert, makes them more aware of what's going on, especially using this at sort of lower doses as well. Then, of course, we have sort of the, quote, speed scene of the 1960s, which is where it sort of blew up and became sort of a big, social drug that was used during this time point. Oftentimes it was used in combination with heroin or just, even on its own. Prescriptions during this time were really easy to obtain, and so the drug was just readily available and easy to come by in this instance. Typically, it was around 1965 where some of the laws started to change and the drug sort of scene started to shift and looked at sort of more of the dangers of these amphetamines. So then we have sort of this return of methamphetamine, right, where we have sort of that, resurgence of this new medication, this new spin on this, where some of these harsher components and solvents are washed away, and the final stage is sort of this more refined drug of methamphetamine here, which has a stronger effect, and again tends to increase some of those effects that we see. All right, let's talk now about the pharmacology of amphetamines. So we're going to switch back over here in a second and actually look at the mouse party again, do a demonstration for one of these. But the chemical structure itself of basic amphetamine molecule is actually pretty similar to some of the catecholamine neurotransmitters. These are things like dopamine and norepinephrine. So again, the structure is very similar to the actual neurotransmitters that we see in the brain. And we're going to see, because of that, they act differently than some of the other drugs that we've looked at here in the past, because they so closely mimic what's already present in our body. So because of this structure, it also allows it to easily cross through that blood-brain barrier. We talked about that a little bit as well, that protective lining or that protective system. It's easily able to cross through that, so it is readily available in the brain. So let's take a look now. We'll switch back over to mouse party here. And we're going to take a look now at our mouse who is under the influence of methamphetamine. So if I go ahead and grab him, pop him into the chair, we're going to move over here and take a look now at some of these effects. So again, we're going to zoom in here on the brain, and we see sort of what we at first seen as a normal structure, but we see these little orange particles here appearing as well, which are actually the meth or the methamphetamine component here as well. I'll point out again, we have our purple dopamine transporters. We also have our dopamine neurotransmitters, those yellow dots in there. And then of course we have our receptor sites down along the bottom. And so you can see the meth gets absorbed up into that axon terminal because it so closely mimics that of dopamine. So the transporters are able to absorb it up in there because they don't know any different. And so what happens here is they actually start to push up into those vesicles and push the dopamine out of those vesicles and into just the general the general axon. And so because of that, these transporters don't really know what to do with all this excess dopamine that's now present. And so what they do is they start working backwards, actually. And so rather than absorbing them from the synapse, that empty space, they start pumping them out back into the synapse. So they're working almost in reverse here, which in effect causes more dopamine to be present in that synapse, able to be absorbed over and over again by that dopamine receptor. And so we can see here this increased binding that happens as those dopamine molecules bind over and over again to those receptor sites. And we get this increase effect going on here as well. And then again, we can zoom out, look at the bigger picture here of what's going on. And what we see basically is part of the reason why meth is so addictive is because it acts again on those reward pathways and makes the user or the person feel those feelings of pleasure and exhilaration, right, from that dopamine binding over and over again in those reward pathways. So we'll go ahead and eject this mouse. But again, you can see it works slightly differently. Not every drug is going to work exactly the same, but we get similar effects happening here. All right, we're going to save some of these for later. We'll come back to this for sure in other chapters as well. But let's go back now to our video or our slides. All right, so we talked about sort of the general pharmacology and structure, but again, let's talk about absorption here. So typically the way absorption happens is that peak effects tend to occur about 1 to 1.5 hours after oral injection, about 5 to 20 minutes after intranasal administration, and about 5 to 10 minutes following any type of injection or smoking of the drug. So you can see how that time course really changes based on how you absorb that medication. It takes longer for it to see an effect if you ingest it orally than if you were to ingest it through the nose or through the lungs or injection. So we talked before about cocaine having a half-life about 1 hour. In this case, amphetamine has a half-life of about 5 to 12 hours. So it's definitely a longer half-life. It stays in this body, in the system, a little bit longer. All right. And again, that was elimination, so it just kind of got off a little bit. So again, half-life 5 to 12 hours, stays in the system a little bit longer than cocaine, but still not an excessive length of time. It generally is typically removed completely from your body within about 2 to 3 days of the last dose. All right, so let's talk now about some benefits or beneficial uses of amphetamine. So it has been used in the past to treat things like depression, especially in the early 1950s and 1960s. Now, not so much, but it did early on was used for the treatment of depression. Also, weight control, right, especially talking now mid-1960s or so, was used as sort of an appetite suppressant, again, to kind of reduce the desire to eat and have more food, and it would reduce weight that way. Let's see. So it has also been treated for narcolepsy. So that's when you just, randomly happen to fall asleep or undergo feelings of sleepiness. And this has been used to help treat this by acting as a stimulant to keep the person awake. It's also been used as treatments of ADHD. So one of the really interesting things about ADHD is that even though people with it tend to experience issues of overactivity or overexcitement, what's really going on with ADHD is that part of the brain that helps regulate that, that control is actually underperforming, right? So that area needs some form of stimulation to be able to perform better and help with the overall, control of actions and things like that. So sort of counterintuitively, amphetamine, these stimulants, help to increase those control centers of the brain, thus reducing symptoms of ADHD. So it has been used for different treatments of ADHD here as well. We also have things like smart pills. This is more of a theoretical side of this, but then it may help improve performance when people are tired or extra sleepy, like we talked about with the soldiers and things like that. However, it might actually work counterintuitively and reduce performance when you start getting to those higher doses. So we can actually see here in sort of this graph some examples of this, where we see on simple tasks, like just base reaction time, we end up seeing actually, faster reaction times at higher doses of methamphetamine. And so it can improve performance that way by, again, making people quicker to respond. But when their response needs to be thought out or more complex, we see that the performance is actually worse. So in that complex task, we see more false alarms, more incorrect responses at the higher doses of methamphetamine. So it might be beneficial for simple tasks, but it looks like it also is likely harmful in more complex tasks. Of course, then we have athletics, just the general ability to improve performance on different physical feats. All right, obviously now we have some causes for concern to discuss here as well. So for causes of concern, number one is going to be sort of this acute toxicity, right? So this is the idea of on small time frame, small windows of use, we get results of paranoia, right? That's often a pretty common effect here, especially on that short term. On the more long-term chronic toxicity, we still see that form of paranoia, but it exists in a stronger form called paranoid psychosis, right? So this is more of a, more in-depth serious effect of paranoia. Especially when this tends to be combined with lack of sleep and even poor nutrition, there's even greater concern here for both the psychological and physical well-being of the person in this case. Oftentimes, again, paranoid psychosis is from extended, prolonged use or chronic use of amphetamines. However, there really isn't any evidence that this is a permanent, effect or factor that has happened, and that once people can remove and stay off of these drugs, that most of this tends to go away. All right, so that wraps up chapter 6, stimulants. We're going to switch over now to chapter 7, talking about depressants and inhalants. All right, so this is chapter 7, talking about depressants and inhalants. So in this chapter, we're going to cover, first and foremost, depressants. So we're going to talk about some of the history and types of those, the mechanisms of action, again, some beneficial uses, and again, some causes for concern here. And then we'll also talk about inhalants, some types and dangers of these as well, but won't go quite as in-depth into those, but we'll still discuss some of those factors. All right, so when we're talking about depressants, let's first kind of just break down sort of the history and how these tend to be organized. You can see over on the right that, depiction of them. You can see most of the time we see these kind of classified in really two ways. We throw alcohol in there as well, but really what we see here are what are known as barbiturates and then benzodiazepines. And so we're going to kind of talk about these throughout the history because they did sort of develop, or at least the more common use of them has sort of been in a linear fashion. So before either of these, or before barbiturates, we had a few types of depressants that were used sort of to help, again, ideally in some kind of clinical medical fashion that were used here. And we have the first one is chlorohydrate, which really was used clinically until about 1870. And helped people to basically sleep better was the idea. It was helped to induce sleep, and it worked pretty quickly. But when people used it over and over again, it led to some pretty severe gastric irritation, right? So some stomach issues. And so it wasn't something that was really a great solution for some of these problems. We also have paraldehyde. This was, again, clinically used until about 1882, so maybe a little bit longer. This was effective because it had a wider safety margin. Remember, we talked about that. That's sort of that effective dose versus the lethal dose, how far apart those are. So this had a wider safety margin, so it was a little bit safer to use, but it had a really bad taste and odor that actually hung around and came out of the breath of the person. So it was, again, replaced over time because of some of those negative symptoms here. So those were before barbiturates. Then that brings us to barbiturates, basically. So this is a different type of depressant that was used first around 1903 was when it was sort of first introduced, and again, became pretty popular during this early 1900s period. And it generally tended to be separated out or thought of to act under two different general methods, either short-acting, rapid onset drugs, or long-acting and delayed onset medications. So those short-acting, rapid onsets usually used to induce things like sleep, acting as a sleep aid, and were oftentimes prescribed in high doses. Those long-acting and delayed onset medications were often used to reduce things like anxiety and were prescribed in lower doses. Now, we did have, of course, some specific concerns here about barbiturates. There were pretty frequent overdose deaths, both intentional and accidental, but oftentimes caused by respiratory depression. So basically, your body would stop breathing because it would get too relaxed into that state. There was also pretty high abuse and dependence of a lot of these medications. Oftentimes reinforcing effects of a drug were related to sort of that rapid onset of effects. So because those effects acted so quickly, it reinforced people to do it over and over again. That's a sort of a psychological phenomenon where we have those stronger links in our mind the faster we see the effect associated with the action of taking the drug. So what this really led to was a need for some safer medications to accomplish some of these similar goals. And what that led to was benzodiazepines. And so these were developed after sort of the barbiturate issues and that sort of time period. And benzodiazepines were first introduced around 1960, right? So we have some examples here. Again, you can see on the chart some of those more common names like Valium, Xanax, things like that. And these affected and had some of the effects similar to barbiturates, but were safer and had less negative side effects. So they still acted to help reduce anxiety, but they produced less drowsiness than barbiturates did. So you could use them more on a day-to-day basis. There was an even larger safety margin, so things like overdose was less of a concern. Physical dependence was more rare, and then overdose really only occurred when combined with other depressants like alcohol or things like that. And again, during the mid to late 70s, some of these like diazepam or Valium actually became some of the highest selling prescription drugs on the market. And so these really sort of took off around that time and became pretty popular to be used in a lot of different ways. However, there was still dependence, right? So they weren't necessarily 100% safe. There was still dependence that could occur. And oftentimes, overdose deaths were more likely when these large doses were taken with other medications. So, when people were dependent on them and they would continue to take them, they might not think about the fact that they were taking them and then also engage in other depressant medications or alcohol and result in overdose deaths. Physical dependence tended to occur usually when the drug was, was leaving the system more rapidly than the body can adapt. So because these drugs got out of the body quickly, the body wasn't able to really adapt to that. And so it needed, more frequent intake of this drug in order to adapt and stay at more baseline levels. So the question really now is, were benzodiazepines safer than barbiturates? And so when we talk about this, again, we don't really now say that that's the case. Really, we say that there aren't many differences. So there are less differences between barbiturates and benzodiazepines as they are within those two categories. So there might be some barbiturates that are safe and some that are dangerous, just like there might be some benzodiazepines that are more safe compared to some other ones. So again, pros and cons to both, and they can be used in different ways, sort of to help with different symptoms. All right, let's talk about the method of action here. So when we're talking about the method of action of these different types of depressants, we look at this in the form of primarily how it affects GABA. So barbiturates affect GABA as basically acting as a separate binding site. So they sort of come into play and can accept GABA and allows it to have more places to bind, thus increasing the effects of GABA. Quick refresher, remember GABA is one of those components that helps to calm and reduce the effects within the body. So it is a general depressant inside the body and acts as a neurotransmitter that decreases activity. And so if we have more binding sites for GABA, that's more decreased of activation amongst the neurons in this case. Similarly, but working in a slightly different fashion, benzodiazepines tend to bind to the already existing GABA sites that are there, the GABA receptor sites that are there. And so again, both of these act and get a very similar outcome, but they're doing so in different ways. Barbiturates are creating more sites for GABA to bind to. Benzodiazepines are mimicking GABA and binding to the already present receptor sites. So again, two different methods, but very similar outcome. And so what we have here is this creates sort of this GABA receptor complex. And so it's this general idea that there's a lot kind of going on here. There's ways to affect this GABA neurotransmitter through mimicking, through adding in multiple receptor sites and things like that. And we're going to talk more about this when we get to the chapter on alcohol next week. And that you're going to see actually acts in multiple ways to affect GABA and other neurotransmitters. All right, there are some beneficial uses of depressants here. We can talk about this for this category as well. Of course, we have anxiolytics. These are basically sedatives that are prescribed to reduce anxiety, right? So we think of a lot of common ones that you might be familiar with, things like Xanax, Valium, some of these other examples here. Basically, anti-anxiety medications, and they're used to generally lower the overall activation or the overall excitement within this neuro component to, again, reduce the effects of general anxiety. Of course, there are causes of concern, right? It's not all beneficial. Yes, reducing anxiety is fantastic, but we do have some causes for concern with depressants as well. So again, with these anti-anxiety medications, we have examples where we can often see inappropriate use or inappropriate prescription of these for different types of medical disorders. For example, obsessive compulsive disorder or OCD can often be prescribed these types of medications, which is an inappropriate use and really doesn't help to solve some of those OCD effects. Same thing with specific phobias. So if you have a specific phobia of something and they prescribe you an anti-anxiety medication for that phobia, again, often not going to work and not really an appropriate solution to that problem. They also tend to be overprescribed. So this is something that's more general across the board, but they can be overprescribed, again, for uses that they aren't necessarily designed or effective at treating. We also have some issues with sleeping and some causes for concern with their use as sleeping pills, right? So, of course, they are oftentimes effective, especially early on, at helping people sleep, but can develop sort of dependency and also, baseline with this to where you need more and more to be able to accomplish the same goal. And so again, it does have some issues in this realm as well. Anticonvulsants, so they can be prescribed to treat things like epileptic seizures. But again, some concerns here are that tolerance can make it difficult to find a dose that's effective, right? So you might need to keep increasing that dose to keep the effectiveness at a stable point. And then, of course, abrupt withdrawal is likely to cause seizures. You have to be really careful coming off of these medications so that you don't have actually increased symptoms during that time point. Of course, also things like abuse liability, both psychological dependence, right? So just having that short acting sedatives, things like, some of those depressants that act really quickly on the body is going to create more psychological dependence because you have that association between the action of taking the medication and the resulting effect of it reducing either anxiety or calming you down. And so we have that psychological dependence that can develop really quickly with this type of medication. Then we, of course, have physical dependence, again, similar to things like alcohol withdrawal, where we get sort of those life-threatening issues with a lot of these depressant medications or drugs. So oftentimes they can come with things like tremors or other effects of coming off of them because our body becomes physically dependent upon them to maintain its normal equilibrium or balance. Of course, we have toxicity effects here, both behavioral toxicity, where different types of depressants can cause impaired judgment and coordination, and oftentimes can, again, cause people to put themselves into situations they shouldn't otherwise be in, or just make poor decisions overall. And then, of course, physiological toxicity. With depressants, they reduce that respiratory activation, that respiratory rate, and so they can cause issues with breathing, oxygen function. And then, of course, they're even more dangerous when combined with alcohol in this way, because they're both acting to do that together. And then finally here, patterns of abuse of depressants. Typically, we see different patterns of abuse for different ages of people. For older adults, it typically tends to be those using prescription drugs, and they've developed a tolerance, and they have to keep increasing their dosage. So maybe they have to go out of their way to find more, or go above what they're prescribed by their doctor. And then for younger adults, often it's just people trying to kind of experience those positive benefits of the drug. But again, later on down the road will cause more of those negative side effects. All right, let's quickly talk now about some inhalants and just kind of go through this quickly to discuss, because they do sort of fall into this category. When we talk about inhalants, we think about things like, gaseous anesthetics. These are things like gasoline, glue, paint, lighter fluids, different things that you can inhale, and often used to be called things like nitrous oxide, right? So this is the idea of sort of the laughing gas medicine that we used to have, and was used as early as the 1800s here in this case. It's often used as propellants in a lot of these, canister type things. It's still often used by dentists and exists in small portions in things like whipped cream containers and things like that. We also have nitrites. So these are different medications that help to relax the blood vessels in the body. They're often used to treat things like chest pain, and they generally increase the blood flow and briefly can lower blood pressure as well. We also have volatile solvents. These are, again, different types of inhalants that are going to, have some of these effects and similar issues that we've seen with some of the other ones. Some examples are things like paint, glue, things that give off sort of those vaporous fumes that produce some of these same effects. Most of the users of these as a drug tend to be young users, oftentimes even grade school children, because they have access to these things where they don't have access to other more hard, quote, hard drugs that exist out there that have to be obtained in other ways. And so these can be particularly dangerous because of their availability, especially to children. All right, let's talk about some of the dangers of these solvents before we kind of move on to the next chapter. So, of course, the dangers here, some of the effects that these can cause. This is not everything, but just some general main things to take away from this. Kidney damage is number one, can affect some of that. Brain damage as well. Also peripheral nerve damage, irritation to the respiratory tract because these are being inhaled. Oftentimes can cause very severe headaches, and then of course death by suffocation because they're taking up the areas that oxygen would be going into the system, not letting that oxygen get in, and people can actually die through this suffocation. So these are actually sort of, I say, some of the almost like the sleeper drugs where they're fairly dangerous, but we don't always think that they are because they're available to us and something we still encounter on a day-to-day basis. But oftentimes some of the more dangerous ones, again, especially for children and people looking for things that don't have access to other drugs. All right, so that was chapter 7. So we're going to move on here in a second to chapter 8, where we'll talk about the medications for mental disorders. All right, the last chapter of this section is going to be chapter 8. We'll talk about the medications for mental disorders here. So we're going to go through, we're going to do a couple things. We're going to talk about the classification of mental disorders. We're also going to talk about early treatment, how this was treated back in the day. Then we'll talk about some things like antipsychotics, some new medications that have been developed, antidepressants as well, mood stabilizers, and then also some consequences here of this pharmacotherapy, of this medical way of treating some of these mental disorders. All right, so when we're talking about classification of mental disorders, the big thing that really comes to mind, the big thing that we use and has been developed and used and adapted over time is the Diagnostic and Statistical Manual for Mental Disorders, the DSM, right? So you guys are probably familiar, you've probably heard this before. We're on the DSM-5, there is the version right now. And this was developed by the American Psychiatric Association and is generally a way to classify and diagnose and group different types of mental disorders. So most of the time, these terms, these definitions, things in this book become standard for all medical health professionals. It helps to keep everything kind of unified across the board. When we talk about mental disorders, there's a few different ones to talk about here. So, of course, there are anxiety disorders. These tend to be characterized by excessive worry, fear, avoidance, things like that. And under the DSM-5, they tend to be classified as things like specific phobias, social anxiety disorder, panic disorder, agoraphobia, which is the fear of going outside or being in large groups, and then generalized anxiety disorder as well. We also have things like psychosis, right, which is a serious mental disorder, which involves basically the loss of the contact with reality, right? You aren't even able to really identify what's real and what's not real. Schizophrenia, which under the DSM-5 is classified really with symptoms of two or more of the following: either delusions, hallucinations, disorganized speech, disorganized behavior, or a lack of emotional response. And so again, these symptoms normally have to last for at least 6 months to be classified as schizophrenia, and also interfere with some form of social or work sort of functioning. So there's a pretty strict requirement here really to be classified as true schizophrenia from the DSM. But I think, we can discuss how that's important in really having clear distinctions in different disorders, or maybe how there's some room to, discuss where this line should be drawn. Then, of course, we have bipolar disorder and its related disorders. There's a few different forms of bipolar, but it tends to be characterized by either depressed or manic symptoms. And oftentimes people don't always fit really nice and neat into one of these categories. But the DSM-5 basically organizes these into either major depressive disorder, which is really only having depressive episodes. So no mania with major depressive disorder, just episodes of depression. And then there's bipolar 1 disorder, which is basically where at least one manic episode and possible alternating periods of depression sort of come into play. And then, of course, we have bipolar 2 as well, which is classified normally as having both manic and depressive episodes in that case. All right, so when we talk about mental disorders, one of the important things to talk about here is sort of early treatment, right? How was this treated and dealt with early on or back in the day, right? So one of the earlier forms of treatment, as crazy as this may sound, is actually malaria therapy. So this was introduced around 1917 to treat general paralysis. And this is basically from syphilis infection of the nervous system that causes psychosis. Kind of crazy to think about. But what they did is they would actually induce malaria, and the fever associated with the malaria was often thought to help improve this psychosis condition. This was eliminated basically once we discovered antibiotics that could cure syphilis, and we no longer needed these more severe forms of treatment. We also have narcosis therapy, which was around the 1920s, where depressants were used to actually induce sleep for a week or more to try and treat some of these mental disorders. Again, efficacy, not the best. We have much better ways now, though this was one of the early treatment methods. Then, of course, we have this idea of thiopentanol sodium, or this truth serum, which was used during psychotherapy to actually help patients express repressed thoughts. So the thought here was that using this to help basically reduce their inhibitions, be more likely to actually say what they, actually were thinking and tell the truth, so to speak, would actually help them treat these mental disorders to try and just actually access and get off their mind what was going on. There's also insulin therapy, which was used early on to treat schizophrenia, where basically repeated treatments were tended to be problematic as patients became basically agitated after a few minutes, and the drug tended to be administered before the seizures began. And so, this wasn't super helpful, but it was used early on, again, to try and treat schizophrenia, but again, had issues with seizures and things like that. We also have electroconvulsive therapy, or ECT. So this early on was used to treat schizophrenia, but really showed no long-term benefits. So it's still used to treat severe depression when patients don't respond to medication. So this is sort of a very severe depression treatment that is still used today. And we'll talk a little bit more about this here in a minute when we get to that. So when we talk about antipsychotics next, there's a few different ones we can talk about here. Medications to help treat psychosis, right? So early on, we had these penothiazines, which was an early group of drug used to treat psychosis. And then they kind of became known more as tranquilizers, right, or neuroleptic drugs. And now we basically call them antipsychotics. So the name is kind of adapted over time in what we actually kind of refer to these as. But when we talk about these and we talk about the mechanisms of action here, we think about this in two different ways. So we have what are known as typical antipsychotics and then atypical antipsychotics. And they work under two different mechanisms of action. So typical antipsychotics, basically, they respond to the nervous system they give the nervous system repeated administration of this dopamine antagonist, right? So what they do is that means they block those dopamine receptors, specifically the D2 dopamine receptors. So again, they're blocking those dopamine receptors, so there's less ability for that dopamine to be binding and sending that signal. Some of the downsides of this, though, is it actually often would produce pseudo-Parkinsonism, so effects similar to Parkinson's disease, where you'd get sort of these tremors and things like that. Then we have atypical antipsychotics, which are basically referred to as serotonin dopamine antagonists. So not just dopamine, but also they block both the dopamine and the serotonin receptors. And these tended to produce less of those pseudo-Parkinsonism, so less things like tremors and issues related to these medications. And so now most of what we use are atypical antipsychotics, so ones that act on both dopamine and serotonin agents. So some of the advantages here of these specific antipsychotics is that they tend to not produce drug dependence. They have relatively small side effects, though some can include things like allergic reactions or even photosensitivity. And one of the more serious ones, depending on the person, could be actually they might lower the white blood cell count in people. And then, of course, some do still produce that pseudo-Parkinsonism syndrome. So tremors of the hands, maybe some muscular rigidity or things like that. But overall, still some advantages here. And the side effects that I just mentioned here as well, like those reactions and photosensitivity and pseudo-Parkinsonism. We talk about their effectiveness here. We also can talk about sort of the long-term effectiveness that kind of counteracts the short-term effectiveness. So oftentimes, short-term, we might see positive effects. It might be relatively good at treating some of these psychotic episodes. But long-term, we actually see pretty bad, not great effects of these medications. Oftentimes it is due to participants just stopping the treatment or stopping the use of these medications. So in one study done, they found that about 3/4 of patients actually discontinued the use of their antipsychotics by 18 months of treatment. So they may have, made it a year and a half or so, but at that point they decided to discontinue and not keep taking them. So there's really no clear evidence whether or not these atypical antipsychotics, most of what's used today, whether or not those work better than conventional drugs at treating these psychotic symptoms. And so it's definitely unfortunate in that regard. We're still making progress, but we have not really unlocked this yet or solved really this problem. And we have some different sort of factors here as well when looking at both children and elderly. So children tend to have, more risk of things like weight gain or metabolic changes, oftentimes more obesity, diabetes, and even some cardiovascular problems. Whereas for elderly patients that take these medications, normally they have increased risk of death from just like cardiovascular issues and things like that. So definitely still some issues here with this type of medication. We're talking about antidepressants specifically. There's a few different ones we can talk about as well. So we have monoamine oxidase inhibitors, or MAOIs. These tend to elevate mood. They increase the availability of serotonin, norepinephrine, and dopamine by inhibiting their breakdown, basically. So they don't get broken down through those enzymes and put back into the bloodstream. They kind of stay and hang around longer because we're inhibiting the ability for them to get broken down. So again, some of the downsides here though is that it can alter that normal metabolism because we're affecting those enzymes that would break these down. Those enzymes can't break down other things that they might need to. Then we have some other typical antidepressants. Things like tricyclic antidepressants. These often tend to elevate mood. So things like, like phenothiazine is an example here, and their mechanism of action is also something to take in mind as well. So the way these work is slightly different. So again, they're still increasing the availability of serotonin, norepinephrine, and dopamine in the synapse, but rather they're interfering with their reuptake. So they're not interfering like the previous example with their breakdown, but instead with their reuptake back into that axon terminal. So because they're not being taken back up, they're readily available to be used as well. So very similar effect, right? But a different method of achieving that. And then one of the downsides here is that they tend to not be effective in all patients, right? So this is more, we don't know exactly why, but some people are more, susceptible to these medications than others. Next, we have what you might be familiar with more commonly are selective reuptake inhibitors, or SSRIs. And we have a couple different types of these. We have just standard SSRI, which is actually selective serotonin reuptake inhibitor. And then we also have SSNRI, or selective serotonin and norepinephrine reuptake inhibitor. So this is, again, similarly acting to prevent the reuptake. You can see sort of in the example here, it doesn't take those neurotransmitters back up into the axon. Instead, they remain in that synapse, able to bind over and over again. So it increases that availability of serotonin and norepinephrine with that synapse so that it can bind over and over. These tend to be safer than some of those other, tricyclic examples, but they also, do seem to work for more people as well. So a common example here is something like Prozac, a pretty common, used pretty readily form of antidepressant. And then, of course, we mentioned this before, but electroconvulsive therapy is another form of treating antidepressants. So this is typically used for the treatment of very severe depression. It's often used in the conjunction with other medications as well, so not solely on its own, but it does tend to relieve the symptoms of depression pretty quickly. So some of those other medications, the downside to those is oftentimes they can take upwards of a couple of weeks before the patients even see benefits of those medications, whereas ECT acts very quickly. Even after that first session, normally you see improvements. That delayed response also of those medications is another reason why patients may struggle to see success with antidepressants. They may take them for a week, see no change or no improvement, and then decide to stop taking them because they haven't seen any improvement. When in reality, they would have needed to just take them for another week or two to actually have that effect be noticed in their behavior. All right, let's talk next about mood stabilizers. So we're coming up here. We're going to talk about mood stabilizers here, and then last end with some of the consequences of this treatment options. So mood stabilizers, we can think of things like lithium is a pretty common one. These are used to treat different bipolar disorders. They tend to be either safe or toxic. Really depends on kind of how they're administered, right? So sometimes if the blood levels aren't monitored, they can become toxic if in the wrong dosage. But if blood levels are monitored and the right dosage is used, they can be fairly safe to use. They tend to oftentimes show issues with noncompliance by patients. So that's because they treat both manic and depressive episodes and mood swings. So oftentimes people with bipolar disorder choose to not take their medication or not take things like lithium because they actually like those manic episodes, and so they don't want to have those reduced. Unfortunately, the way this medication works is it has to kind of work and reduce both of them. Oftentimes patients report sort of a more numb feeling, and so they risk those depressive episodes to achieve those manic episodes as well. So they'd rather have that than give up the manic episodes and take this medication. So we see issues with noncompliance quite often with this, where patients don't want to take this medication. Also really interesting here, the mechanism of action here is actually unknown. So the more we learn and the more we discover about these, the better we might be at using them or coming up with better alternatives here as well. So some examples of other mood stabilizers I'll just mention, things like valproic acid, carbamazepine, and lamotrigine. So these are just some other examples here of mood stabilizers aside from lithium, which is one of the more common. All right, lastly, let's talk about some of the consequences of pharmacotherapy. So this is, again, the use of medication to treat different psychological states or disorders. So we can see this graph here, and this is basically the average amount of participants that were in psychiatric hospitals over the years. So the more we've used these medications to treat different psychiatric disorders, the less we've seen patients need to be put in psychiatric hospitals, which on one hand is a very good thing. It means we are treating a lot of these issues and seeing less people put into these places where we just sort of have nowhere else to put them. And so this is a very fantastic piece of data. What's not so fantastic is the other side of this, is we also have seen an increased rate of imprisonment and homelessness with these people, with people with different psychological disorders. And so typically more mentally ill people tend to be jailed each year than are admitted to state mental hospitals. So while this graph shows the psychiatric hospital decrease, we don't see as the increase in incarceration rates. And also about a third of every homeless person in the United States, at least, tends to suffer from some form of serious mental illness. So it's certainly still a problem that we need to continue to work to solve, but we have made some improvements if you look at it from that perspective. All right, well, that is the end of this chapter and this section. So I'm going to wrap this up here. Thank you all.